You are suffering from chronic hemorrhoids. You buy the creams, you take the fiber supplements, and you sit in warm baths, but they just keep coming back. What if I told you that you are treating the wrong end of your body? What if your hemorrhoids are actually just a warning sign that your liver is congested? Today we are exposing the anatomical root cause. This video is for educational purposes only. If you experience rectal bleeding, you must see a doctor immediately to rule out serious conditions like colorectal cancer. Do not self-diagnose based on a YouTube video. Always consult your physician. Now let's clear up the confusion. Hemorrhoids are not a skin condition. They are swollen veins in the anus and lower rectum. Basically vascular cushions that have become enlarged under pressure. They behave more like varicose veins than a rash. And that matters, because bleeding from this area is not something to guess about. Rectal bleeding can happen from hemorrhoids, yes, but it can also happen from fissures, polyps, tumors, and colorectal cancer. That is why symptoms should be taken seriously, not self-diagnosed from a search result or a short video. So the real question is not just, how do I calm the symptom today? The real question is, what is driving the pressure in the first place? Because in vascular medicine, pressure is the language the body uses when flow is being obstructed. Now let's talk plumbing. The body is not just a pile of organs, it is a pressure system. And in that pressure system, the liver is not sitting off to the side like a bystander. It is the major filtration hub for blood coming from the digestive tract. The portal venous system carries blood from the stomach, intestines, spleen, pancreas, and gallbladder to the liver, and the portal vein is formed mainly by the superior mesenteric vein and splenic vein. The liver gets most of its blood flow through this portal route, with the hepatic artery supplying the rest. Think of the portal vein as the main highway carrying nutrient-rich blood from your gut to the liver. That blood is supposed to move with low resistance, pass through the liver's microscopic channels, and then return to the heart through the hepatic veins and inferior vena cava. In normal physiology, the liver is designed to process that blood efficiently. The problem begins when resistance rises inside or around the liver. Here is the nuance that gets missed online. The rectum does not drain only one way. The portal system drains much of the gastrointestinal tract, but the lower rectum has a mixed venous drainage pattern, which is why the anatomy is more complex than a simple everything goes straight to the liver story. That distinction matters because the lower rectum can be involved in both local venous problems and portal system problems, depending on what is actually happening in the body. When the liver is healthy, the system stays low pressure. But when resistance rises inside the liver, most commonly from chronic liver disease or cirrhosis, the portal pressure climbs. That condition is called portal hypertension, elevated pressure in the portal venous system caused by increased resistance to blood flow. And when portal pressure is high, the body starts improvising detours. Collateral veins open up so blood can get around the blockage. One of those detours can involve rectal varices, which are portosystemic collaterals related to portal hypertension. That is not the same thing as hemorrhoids. Hemorrhoids are swollen veins in the anus and lower rectum. Rectal varices are a different entity with a different mechanism. So the real lesson of the portal vein is this. Blood flow problems do not always announce themselves where the problem started. Pressure can travel downstream, and the body will show you the weakest link in the system. In some people, that weak link may be the rectal venous network. In others, the issue is purely local. That is why a careful medical evaluation matters. Rectal bleeding has a broad differential, and portal hypertension is only one possibility, not the default explanation. Now we get to the pressure cooker. One of the biggest metabolic drivers of liver congestion is excess fat accumulation in the liver. what clinicians now call steatotic liver disease, including MAS-LD when it is tied to metabolic risk factors like obesity, type 2 diabetes, and abnormal lipids. Fatty liver often has no symptoms at first, but it can progress from simple steatosis to inflammation, fibrosis, and ultimately cirrhosis. Here is the key physiology. A fatty liver by itself is not the same thing as portal hypertension. But as liver disease progresses and scar tissue builds up, resistance to blood flow inside the liver rises. That elevated resistance is what pushes portal pressure upward. In cirrhosis, scarred liver tissue increases intrahepatic vascular resistance and contributes to portal hypertension. Cirrhosis accounts for more than 90% of portal hypertension cases. Think of it like a drain that used to be wide open, then slowly becomes narrowed by thickening tissue. The blood is still trying to move through the portal system, but now it faces resistance. When resistance rises, the pressure rises too, and that is the definition of portal hypertension. Portal hypertension is high blood pressure in the portal venous system, caused when blood has trouble flowing through the liver. And when pressure builds in a venous network, the body looks for detours. It opens collateral pathways. In portal hypertension, those detours can include varices. In the lower rectum, that can mean rectal varices, dilated collateral veins related to portal hypertension. Rectal varices are an uncommon manifestation of portal hypertension and are distinct from hemorrhoids. But I need to be precise. Portal hypertension does not mean every person with hemorrhoids has liver disease. In fact, one major review notes that patients with portal hypertension and varices do not have an increased incidence of hemorrhoids. That is why smart medicine separates local hemorrhoids from portal hypertension-related rectal varices instead of lumping them together. So the real root cause story is not fatty liver magically causes hemorrhoids. It is this: metabolic dysfunction can drive fatty liver. Fatty liver can progress to fibrosis and cirrhosis. Cirrhosis can create portal hypertension, and portal hypertension can produce venous detours that may involve the rectal area. That is the biologic chain worth taking seriously. MAS-LD is linked to metabolic risk factors and can progress to fibrosis and cirrhosis, which are the major structural drivers of portal hypertension. Here is the principle that changes everything. You do not fix a pressure problem by treating the visible bulge alone. In medicine, if the upstream resistance is still there, the backup returns. That is why the real solution is not just symptom relief. It is correcting the conditions that are driving pressure in the liver and the venous system. For fatty liver disease, evidence-based first-line care is lifestyle change, healthy eating, weight loss if needed, and regular exercise. The NHS advises at least 150 minutes of exercise per week, plus weight loss when overweight and limiting alcohol. So the first lever is metabolic pressure. That means cutting the fuel that feeds fatty liver, excess calories, ultra-processed food patterns, and too much alcohol. In alcohol-related liver disease, the main treatment is stopping alcohol, and in fatty liver disease, weight reduction and healthier eating are core treatments. The second lever is stool pressure. Hemorrhoids are often made worse by constipation and straining because that increases pressure in the veins around the anus and rectum. So even when the liver is part of the larger story, you still have to calm local pressure. Hydrate, keep stools soft, and avoid sitting and straining on the toilet. Now, if a person truly has portal hypertension, that is not a supplement problem. That is a hepatology problem. Specialists may use medications such as non-selective beta blockers and in some cases endoscopic procedures or shunt-based interventions depending on the cause and severity. That is why I'm not going to sell you a miracle cleanse as if it were a cure. Real liver care is measured, supervised, and evidence-based. If you're dealing with ongoing bleeding, black stools, dizziness, or worsening symptoms, you need medical evaluation, not internet diagnosis. Urgent rectal bleeding should be assessed promptly, especially if the stool is black or dark red or there is significant bleeding. So the solution is not magic, it is pressure management. Improve liver metabolism, reduce alcohol, lose excess weight if needed, move your body, keep the bowel moving smoothly, and work with a gastroenterologist if you have bleeding or suspected portal hypertension. That is how you reduce the backup instead of chasing the symptom. If you have rectal bleeding, black stools, or severe symptoms, seek prompt medical care to rule out serious causes, including colorectal cancer. At this point, the smartest protocol is not flashy, it is biological. If the liver is the upstream bottleneck, the first job is to lower metabolic stress and reduce resistance inside the system. In MASLD, the foundation of care is lifestyle change, diet quality, exercise, and weight loss when needed. AASLD notes that even 5–10% weight loss can improve liver fat, inflammation, and fibrosis. So here is the practical reset. Stop feeding the fire. Cut back alcohol if it is part of the picture, reduce excess sugar and refined foods, and build a routine that helps the liver unload fat over time. That is not a miracle claim. It is the current evidence-based starting point for fatty liver care. Then protect the plumbing below. Hemorrhoids are often worsened by constipation and straining, so the bowel side of the equation still matters. Softer stools, enough fluid, and less pressure on the toilet. And if bleeding does not settle quickly, it needs a doctor's assessment, because rectal bleeding has more than one possible cause. Now, if portal hypertension is actually part of the picture, that is a specialist problem, not a supplement problem. NIDDK and AASLD describe medical treatment for portal hypertension and cirrhosis complications, and in more advanced disease, hepatology referral is prudent. That is why I keep the supplement language disciplined. If you mention a product like Live Pure, frame it as an optional adjunct people sometimes explore for general wellness, not as a cure for hemorrhoids, not as a cure for portal hypertension, and not as a replacement for medical diagnosis or treatment. NCCIH warns that natural does not automatically mean safe, and herbal or dietary supplements have been linked to liver injury in some cases. So the honest message is this: support the liver, don't worship a capsule. The real protocol is food, movement, alcohol reduction, bowel mechanics, and specialist care when symptoms demand it. That is how you reduce the pressure at the source instead of chasing the flare-up after it appears. And one last time, if you have rectal bleeding, black stools, dizziness, faintness, or bleeding that lasts more than a day or two, see a doctor promptly. Do not assume it is just hemorrhoids. Get evaluated, rule out serious causes, and then build the right plan with your physician or gastroenterologist.